Good morning, good afternoon, good evening to you all. Welcome to the 7th day of the online advanced course on Biomedical Imaging 2024. Today, we will have a panel of experts to talk about MRI. I would like to remind you that you can send your questions via the Q&A chat box or express your intention to ask your questions orally by activating the raise the hand button. All questions will be answered at the end of each talk. Now, without further ado, I give the floor to Professor Ana Salomé Pires from the Faculty of Medicine of the University of Coimbra.
So good afternoon to you all once again. Today's session will then be dedicated to magnetic resonance imaging, and as a first lecturer we will have Dr. Andrea Gaspar. She is junior researcher at the Evolutionary Systems and Biomedical Engineering Lab, where she focuses on open source techniques and both acquisition and reconstruction methods in quantitative MRI, with the aim of improving accuracy and spatial resolution of T1 mapping techniques. Dr. Andrea, we thank you so much for accepting our invitation to talk about the physical basis of magnetic resonance imaging. The floor is yours, and you can start sharing your presentation.
Thank you very much for inviting me. I'm happy to contribute to this course. So I'm work in Instituto Superior Técnico, in Instituto de Sistemas e Robótica de Lisboa, e o meu trabalho foca-se. I'm sorry, it's better in English, right? So my work focuses on MRI, especially cardiac MRI. But in this course today, I will talk about the physics of MRI imaging. So I will start by talking a little bit about the principles of MRI. How can we encode the spatial information in this technique? Also, how can we differentiate between different tissues with the different image contrasts? And at the end, I will talk a little about different image artifacts that we can find in those images, and how it is important to identify them and also to try and correct them. So in MRI, we are really interested in the water molecules in the human body. So here we have an image of a brain, an MRI image of the brain, and the water is one of the abundant molecules in the human body. And in this case, we are specifically interested in the proton that is present in the nuclei of hydrogenium. This happens because the proton will have a spin because it rotates and presents itself as a little magnet. And why is this important? Because we are able to change this with the magnetic resonance equipment and measure the changes that we have in those little spins. So when we have all those little magnets, without being within the magnetic resonance equipment, they are randomly distributed in the body. To obtain an image, what we do is to apply a static and external magnetic field that we call B0, that will allow to align all those spins in the direction of B0. And this allows us to create magnetization that we can measure and we can manipulate. And how can we create this magnetic field that presents high intensities? We do this with superconductive materials that have to be refrigerated. So all the building have to be prepared for this with a shielded room, so it is not affected by external sources. And what we are able to do with that main magnetic field is to align the spins as we show in here. Another thing that is important to mention is the fact that the intensity of those fields in the clinic is usually between 1.5 Tesla or 3 Tesla, although there are been some research centers that use 7 Tesla or a little bit more. But currently, most of the machines present between 1.5 Tesla and 3 Tesla. But to obtain the image, we have to understand how this magnetization works and how it is that's dynamic. So when we apply this magnetic field, this static magnetic field, we align the magnetization along in the direction of that field. And usually by convenience, we define it as the Z axis, as we can see here. And what we do to be able to measure those changes is that we apply a secondary field that we call B1 that is usually performed in a transverse direction in order to rotate that magnetization into a different plane. This is applied by impulse that presents a specific frequency, usually of the order of the radio frequency, the radio frequency, and it's called the resonance frequency. And this is important because we will see a little bit further, will allow us to define from where it is that that magnetization comes from the body. And this radio frequency pulse can have different angles. For example, if we apply a 90-degree pulse, we will have that magnetization rotated into the transverse plane. If we apply a 180 pulse, we will have an inversion of the magnetization. So this is more or less what we are able to obtain. And once we finish the application of that radio frequency pulse, what happens is that the magnetization still rotates around that Z axis with a specific frequency. And that frequency, it's called Larmor frequency, and it's given by this expression. So it depends on the main magnetic field and is usually of the order of the megahertz. And this is important for, especially for the water. As we'll see in the artifacts, a few changes in those frequencies can lead to artifacts. And how can we measure that rotation that happens and that those changes that happen to the magnetization? We can do that by a similar phenomena has occurs, for example, in the car alternator, where the changes in the magnetic field will generate an electric field that we can measure. In the case of the car, is the wheel movement that generates that change in the magnetic field. In the case of the magnetic resonance imaging, is or in this case we are still talking only in the spin level, so is the nuclear part. We will have the rotation of the magnetization will change the magnetic field, and we are able to detect that. And how are we able to measure? We use these coils, these receiving coils. We have here at the left one for the heads and here for the torso. We have different channels, which one will measure in the different location. And the idea here is that the changes in the magnetization due to that precession will be able to generate an electric field in those antennas, and we can measure those changes. So to summarize, what happens in the magnetic resonance nuclear experiment? We have the main magnetic field that will align all the spins and create the magnetization along that field, which usually is defined as the Z direction. We apply then a secondary field, B1, which will rotate that magnetization into a transverse plane or invert that magnetization. And then we stop B1, and the spins will still precess, will still rotate around Z, and that rotation is able to, and with that rotation, we are able to measure the signals in the receiving coils. So what we have is here in a schematic form, we have the Iman that creates the main magnetic fields. The spins will be orientated in that direction. Then we apply a B1 that will excitate those spins and change the magnetization. And the rotation around Z will generate a difference in the magnetic field that we are able to measure with the receiving coil. We can see here that there is a frequency in the measured signal, and it decays along the time because it will loses that excitation. And I will talk a little bit more about that in a few minutes. So we have this signal, and in order to obtain the signal in the image space or in the dimension space, we'll apply the Fourier transform to obtain, in this case, only one peak because we are not doing any spatial encoding, but that in the intensity of this peak will be proportional to the proton density. So how can we understand, how can we encode spatially each part of the body? For example, if we have here two structures and we want to resolve them, we want to identify each one in an image, we can see that if we apply only the main magnetic field without any gradient, what we see in the end is only one peak because the frequency is similar in all the sample. However, what we can do is to apply a gradient of the magnetic field, so the direction is the same, but what we apply is a difference in the intensity of the field in order to have different frequencies along that direction. We can see this is a diagram that we usually use for the sequence. Is called the pulse sequence design. And in this case, this is applied, for example, in the x direction, we will apply a gradient. And in that case, what we are able to see is here a signal where we have different frequencies. And by applying a Fourier transform, we are able to see two peaks, one for each object, and the intensity is once more related with the proton density. In this case, because the gradient is applied at the same time as the acquisition, this is called the readout direction or the measurement direction. Okay, so we are able to define where what is the position of a specific region of the body in this direction, but we have two more directions that we need to resolve. So another way of doing it in another direction is to define a slice within which we are able to excitate. So if we apply once again a gradient, but now in the Z direction, we will have a different frequency as before. A different frequency, for example, here we'll have a weaker magnetic field, and in the head a stronger magnetic field. And if we apply a radio frequency pulse, the B1 that I referred before, with a specific frequency that is defined by the slice that we want to obtain the image, will excitate only that part of the body. So all the signal that we are able to measure comes only from that part of the body. So summarizing the two directions that I already talked. So we have the slice direction that we apply a gradient in that direction, at the same time has the impulse to define the position of the slice and also the thickness of the slice. We have the readout or the measurement direction. As I said before, this is performed at the same time as the acquisition, and this in the frequency domain that corresponds here to this signal, but in this case in 2D we will have here a line in K-space, and I will talk a little bit more about this K-space, which is the frequency domain that we obtain the signal, and with this gradient we are able to read one line. So there's one direction missing, and for that direction, what we are able to do is to apply another gradient, but before the measurement, because if we apply that gradient at the same time, what we will be doing is to rotate this direction in here and not acquiring different lines. I'm sorry. So what we do, what that does is to dephase the signal before the measurement in order to have different phases. But what happens is that for obtain all the lines, especially when we are acquiring this Cartesian way, in this Cartesian way, we have to repeat this as the number of lines that we want to acquire. And for that, that is especially what makes MRI a slow process. One thing that is important to notice is two parameters that usually allow to define this technique is the time, the echo time, which is the time between the beginning of the excitation and the measurement, and the other is the time of repetition, which is the time that goes from one repetition or one building block to the other. As I was saying, this requires the repetition of the sequence many times, one which with a different phase encoding gradient here in Y that allows to obtain all the different lines. And in here, and those lines, as I said before, corresponds to the frequency domain. And why is this important? Because we acquire the data in the frequency domain, and only through the Fourier transform we are able to obtain an image domain. Here, there are a few things that are important to take into account about this K-space, which is each point in K-space contributes to all the locations of the image, and each point of K-space represents a frequency and a direction of that frequency. I will show you a little bit further one artifact where a peak in one of those frequencies will lead to zebra pattern on the image, and it is because of this. Another thing that is important to take into account is the fact that the extent of K-space represents the resolution, because the points in the center of K-space represent low frequencies, while points more distal of K-space represent high frequencies. Another thing is that the spacing between the points determine the field of view that we image in the body. So to have a little bit more sensitivity to those characteristics of K-space, what we can see here is if we eliminate the high frequencies and only take the center of K-space, in this case 20 lines, we will have a blurred image, because we are not able to describe correctly the high frequencies of the image that corresponds to parts of the image where different contrasts or different tissues present a border between them. Another thing is that I'm sorry, the difference between the lines, so the spacing between the lines determines the field of view. So if we, for example, instead of acquiring all the lines, only acquire half of the lines, what happens is that we reduce the field of view. And probably you will have this artifact, which is called the wraparound, where the image that it's not included in that new field of view will be wrapped around and will show in another part of the image. And this is one of the artifacts that I will talk a little bit further. So, we already know how to spatially define the image, how to do a correspondence between where the image, the object is, and where those tissues appear in the image, but we still need to differentiate between different tissues. And for that, one concept that it's really important is the concept of relaxation. Relaxation is what happens before, after we switch off the radio frequency pulse, the V1 that I talked earlier. When we switch off that impulse, that pulse, what happens is that the magnetization relaxes and goes back to the equilibrium state. And that happens, can be described in two ways. First of all, is the recovery of the longitudinal magnetization, where the magnetization in the Z direction will gain the intensity that it had before. And this is described by an exponential curve where the time constant is T1. Another phenomenon that happened is the fact that the transverse magnetization decays. And this happens because the spins that contribute to that magnetization will dephase, so they will lose that coherence and also decay, but in this case will be governed by the time constant T2. And usually T2 is shorter than T1 due to that the easier way of dephasing of the spins. So why is this important? Because with this, we are able to differentiate between tissues. And by changing the acquisition parameters, for example, TR and TE, so the repetition time and the echo time, we will be able to have different contrasts and differentiate between different tissues. For example, if we want to have an image that it's only determined by the differences in T1, we can change the time of repetition, while the echo time is associated with changes in T2. So just so you have an example of this, let me just drink a little bit of water. This is important. For example, in here we have the standard parameters for a healthy subject for the values of T1 and T2 in the white matter and gray matter. We can see here that, for example, at 1.5, this also changes from a field. It's determined by the field strength. We have a difference between T1, so we will able to change to see it differently with the image that is weighted in this parameter. So how can we change the acquisition parameters in order to have, in order to differentiate those tissues? We can start from the proton density, and in this case, if we use a long TR, what we are doing is to relax, to wait for the longitudinal magnetization to completely recover. And in this case, the equilibrium magnetization that in here is represented as M0 will be defined by the proton density. And if the time of echo is short, we don't have time yet for the decay due to the T2 parameter, and the image will be specially dominated by the proton density, as we can see here, and where the gray matter it's more intense. On the other hand, for example, we want to see an image that is weighted in T1. Intensity, the differences in that intensity is determined by the parameter T1, and if we also maintain the short T, the T2 value will not. And as a consequence, we will have a signal that is dominated by T1, and we can differentiate tissues that are due to T1 differences. Finally, if we want T1, T2 weighted image, we can use a long TR, so this is not governed by T1 anymore, and wait a longer time of echo in order to be able to measure differences due to the parameter T2, as we can see in this image where there is the cephalorhynchidian liquid presents a higher intensity. So this is how we can differentiate between tissues, but there are still a few facts that I want to talk about magnetic resonance imaging before going into the artifacts. First of all, does not depend on ionizing radiation, which is a really big advantage of this technique. However, it requires strong magnetic fields, which requires specific equipment. The room has to be shielded from the exterior. Uses as well some receiver coils, um, and this can lead to some characteristics that we have to be careful. Mainly, one of the potential problems of MRI is the fact that the field is always on. So, and it's really strong. So any ferromagnetic objects that go into the room can be projectiles that can injure people. So this is really important to be careful with this. Um, uh, there are a lot of different rules and schemes, workflows, especially for the technicians, to be sure that there is no ferromagnetic objects going in the scanner. Also, another thing is the fact that if we apply the radio frequency, the B1 field with many times, this can lead to heating of the tissue. Although there are a lot of hardware limitations for this not to happen, and there is usually this is not something that happens often, but we should be careful about this. Another thing is the acoustic noise. Where some people can be really discomfortable about this because it is really noisy, and this is another thing that the building or the room has to be shielded as well from this. And along with the acoustic noise, we also have people that are claustrophobic and have really many difficulties of performing this exam. Finally, because we change the magnetic field and the gradients with high frequency, that lead to acoustic noise, but can also lead to peripheral nerval stimulation, and this can be really uncomfortable for the patient. So when we build a sequence, when we choose the parameters in the control room, we should be aware of these problems. So I have here one video where we can see how this can be dangerous. In this case, it was a chair, probably it was near the door. They didn't were not aware that they were so close, and as I said, because the magnetic field is always on and we cannot see it, something like this can happen. Of course, in this case, it was no one injured because there was no one there, but this can be a problem. So now I want to talk a little bit about image artifacts. Image artifacts are something that it happens with a lot of frequency in the clinic, and it is really important to identify them so we don't do some diagnoses that are wrong or confuse them with some pathology. So it's really important to understand where it is, and also why it's happening, so we are able to correct them and have an image that has diagnostic value without those confounding factors. So in here it's important to know where it appears in the image, why it appears, and how can we solve those problems. And why can it appear? There is a lot of different causes. For example, there can be hardware issues, has power supply stability, problems in the calibration, software issues as well. For example, we think that we are applying a specific gradient, but due to a problem in the hardware or a problem in the software when correcting the values, we don't apply the correct gradient or the timing of the gradient. Another thing is for physiologic reasons, for example, blood flow, motion due to respiration, or even cardiac motion. If we don't account for those factors, that can lead to artifacts. And also due to physics, because there are, for example, frequencies that if we don't sample them can lead to artifacts, as the Gibbs ringing that I will talk a little bit further, and also due to changes, for example, in the susceptibility of different tissues that can lead to artifacts. So I have here a list of artifacts. I will try and explain each one a little bit further. Um, and there are more artifacts than I'm listing here, but those are the ones that I will go into more detail. So the chemical shift. The chemical shift happens because we are interested in the signal that comes from water. However, the signal, if we have fat in that sample, fat presents a frequency that is slightly different from water. And what happens is that when we translate that frequency into a position in the image, and because we usually use frequencies to define the position, as I explained earlier, there is a mismatch between the position where the fat really is relative to the water and where it appears in the image. And we can see here in this example, this schematic, where we can see here that the fat will have a different position than the water, and this usually happens of the order of 2 or 3 pixels. That would be enough to create this artifact. We can see also here, for example, where there's no chemical shift, and in the second image we can see, let's okay, where we can see here where we can see that is already part that is uh, hypointense, and that corresponds to a shift of the water regarding to fats. And this usually happens in the phase in plane along and along the slight direction, and it's related especially with the bandwidth or the time that we take to read each line. So what I have here another example of this, where we have the ecoplanar imaging, where we acquire all the case space at the same time. There is another artifact related with this sequence that I will show a little bit more in a few minutes. And in this case, because we read all the lines after only one radio frequency pulse, there is a low bandwidth. And as a result, there is a shift, and in this case it's not only a few pixels, but because the bandwidth is so low, that we can see here a shift between the fat that should be here near the posterior part of the scalp, and the place where it appears in the image. And there are a few ways of solving this. One solution is to apply suppression pulse that allows to remove the signal from the fat, and because frequency, we can identify that frequency and remove it. It's not always possible, but it can be used in some applications. Another way is to decrease the field of view, to try and remove that part, or also try and work in a lower magnetic field where this problem is um, less problematic once the difference in frequency will be lower because it's proportional to the field intensity. So we can now talk a little bit about one thing that I already showed you before, which is the wraparound or aliasing. As I showed before, if we change the distance between the points, or in this case, the lines in a case space, the frequency domain, what we do in the image is to reduce the field of view. And if the field of view is shorter than the object that we want to obtain the image, what happens is that there is a wraparound of the signal that will appear in the other part of the image. This happens when we don't account for the Nyquist limits, for the sampling frequency, and what happens is that because we have different frequencies, the frequencies that are higher will appear in the other spectrum of the image. This usually happens in the phase encoding direction, the one where I show you that we repeat for each line before the acquisition, and it can happen in different situations. And how can we solve this? The obvious solution is to increase the field of view. However, this can have the disadvantage that probably to maintain the acquisition time, you have to decrease the resolution. Another option is to use surface coil that is near the part of the body that you want to image, and in that case, because the intensity is higher, the other part of the body will not appear as intense and will not be problematic in the interpretation of the image. Um, and also has the fat presence. We can also use saturation bands in the positions that we are not interested in, and that could eventually appear on top of the region of interest that we want to obtain. Okay, now I will talk about the ecoplanar imaging artifact, the N/2 artifact that I also talked before. I didn't talk about this artifact, but about this type of imaging where we acquire all the case space at the same time. This corresponds to acquiring all the lines after only one radio frequency pulse, and we obtain this by applying those those gradient blips that allows us to change from one line to the other. So what happened here is that we read this line in this direction, then we apply the blip that will jump one line, and then read the line in the other direction, because it is the gradient in this case is negative, is inverse of the previous one. This is a great way of acquiring the data in a fast form. However, if there is some inconsistency in the timing of the gradients or in the area of the shift that we are not accounting for between the lines, this can lead to defects. So, to understand better how this works, if we acquire the whole case space and only represent the odd and even lines in the image, what we get is those images. If we sum them, then we will have an image without artifacts if everything is consistent, if everything goes as planned. However, If, as I said before, there is a difference in the area or in the timing of the gradients, there will be some replicas of the object that can appear superimposed if the FOV is small enough. It will be superimposed in the image, and this ghosting artifact can also be problematic when interpreting the images, and especially if we are using quantitative, we are acquiring quantitative information, for example, with diffusion. This can lead to, this can build up to problems in the quantification. And how can we solve this problem? We can uh, signal are correct in to correct where the lines are located to put them in the correct place. We can use calibration scans to know how this deviation occurs, and also minimize the residual fields by shielding the best possible the coils that apply the gradients. Okay, so these changes in frequency will always lead to, if we are not expecting, can lead to artifacts. And another problem with changes in frequency or frequencies that we are not able to correctly represent is the ones that happen when we have this Gibbs or truncation artifact. So this truncation artifacts happens when we are not able to obtain the high frequencies of K-space, that frequency domain. If we don't have those high frequencies, we are not able to correctly represent the boundary contrasts that change rapidly. So what happens is that instead of having this intensity profile perfectly represented, we will have lower frequencies, and this will appear in the image. How can we change this? We can solve this problem by, for example, increasing the matrix and allows to sample the high frequencies in the better way. And we can see here the Gibbs artifact here in the image, that when we increase the matrix will not appear anymore. Another artifact that appears, and this can depend on the subject as well, it's the motion artifact that usually presents in the phase direction. This happens because it's the time between one line and the other is longer than when we are reading each line. Changes in the position can lead to phase errors and lead to ghosting, for example, in the image. And this can be due to this can have different causes. For example, the patient can move due to, for example, he is uncomfortable, they want to swallow the saliva, they want to breathe a little bit more profoundly, and this can lead to motion. Another thing that happens is the respiratory motion. If we don't account for that, can lead as well to artifacts. And because, as I said before, different positions in different lines are represented in a different way in the image, and that can lead to artifacts. One solution is we can, if the acquisition is short enough, we can apply, we can ask the subject or the patient to hold their breath during the acquisition. If this is not possible, there can be as well, we can use some gating between the acquisition and the respiratory motion in order to acquire only specific this respiratory. We account only for specific respiratory phases, and that way it is consistent along the acquisition. In addition, There are also motions related with the pulsation, for example, the presence of flow, the fact that the spins in the blood goes around different slices in a fast way. We can as well, in the case of the cardiac magnetic resonance imaging, we need to have synchronized acquisitions with electrocardiography to be able to only acquire in specific cardiac phases, and also has it's represented here saturation bands. We can see here, for example, due to this pulsation, the aorta can be represented in this case in different positions, that when it's corrected, we are not able to see it anymore. So now another thing that is another artifact that is really important, especially for the gradient echo sequences, is susceptibility artifacts. Those artifacts happen when there's different susceptibility values between tissues that are near each other. This leads to inhomogeneities of the main magnetic field, and has a consequence, the T2 star value that is associated with the dephasing of the spins will decay a lot faster, and this will lead to a signal drop. This is worse when the time of echo is longer, because as I showed before in that decay curve, it is already near. If the time constant is shorter, it will decay a lot faster, and when we acquire, it is already not there any signal to it. And it happens also more, is proportional to the intensity of the magnetic field. I have here an example where we have a surgical clip, that we can see that it is more prominent if we use time of echo that is longer. Those susceptibility I'm sorry. Those susceptibility artifacts can also have a high impact in the echoplanar imaging that I already talked before. This can happen within the slice, and in this case what will happen is that because there is a susceptibility difference within the slice, it will lead, as I said before, to a signal loss in that location, or in plane, that can lead to geometric distortions, because we think that the frequency is specific to that location, but because of the changes in the main magnetic field, those inhomogeneities, the frequency will change, and the signal will appear in the image in another location that it's not the correct one. Solutions for this problem: we can do some post-processing correction. If we know what is the variations of the main magnetic field that lead to those factors, or do some be sure that the shimming, the B-naught shimming that is responsible for maintaining an homogeneous field, is optimized the best we can. Okay, so those susceptibility artifacts appear, for example, também in the cardiac cases, where there is a sensitivity to the frequency of there's variations in the frequency of the signal that appear as well as a signal loss. Now, we can have a different type of artifacts that can be related with changes of interference due to radio frequency signals. For example, in here, this zipper artifact usually happens when there is some external radio frequency signal that comes into the room. For example, if the door is not correctly closed, if there is an equipment that is not correctly shielded within the room, or if the cables that are usually used to connect to the scanner, it's not correctly shielded, and this will appear as this stripe, this line artifact in the image. Another thing also related with these RF signals that come from the exterior are, for example, this zero artifact or RF spiking, where some interference from the exterior can lead to these peaks in the radio frequency signal that we are reading. So what happens is that we have a peak in K space in that frequency domain. And because each point in K space represents a frequency in the whole image, that frequency will appear with a higher intensity related to the object that we want to obtain the image. So in this case, we can see here is that we will have, in this case, we have this horizontal, this vertical pattern because it is near the center. But if we have, for example, in this direction, in this position, we'll have this stripe that is more rotated. What can we do to solve this problem? We can, for example, use filters to try and eliminate those peaks, or repeat the acquisition in order to be sure that it doesn't happen again. So with this, I conclude my presentation. I want to thank all the help that I get to do the slides and this presentation. And I wanted to thank you for hearing me. If you have any question, let me know. I'm happy to reply.
Thank you so much, Dr. Andrea, for this very clear presentation and overview on the basis of this technique. For now, we don't have yet any question. I have just one quick question related with these image artifacts that you very clearly explained, and related with another previous session in which the main topic was the artificial intelligence. How do you see the potential of these the new technologies of artificial intelligence to help mitigating these image artifacts, and of course, consequently, contributing to a more accurate interpretation of the images? Is there any room for improvement with these techniques?
There is a lot of work performed lately in that field, especially one thing that we have to be careful is that we want, for example, if we are using neural network or a deep learning method, we want to be sure that it is constrained in some way to the physics information that we use to acquire the image. This is important because we don't want the network to learn something that it's not there, to create something that it's not there, and can lead to a wrong diagnostic. So there is a lot of work performed to try and remove those artifacts, especially, for example, I talk a little bit about what is used in the clinic in terms of field strength, which is 1.5, 3 Tesla, eventually 7 Tesla for neurological studies. However, one of the trends, because specifically because of AI, is to try and use that type of algorithms to improve the images that we obtain at low field. Because it is cheaper, a lot of places would not have access to the high field case, and it's able to remove some of the artifacts, especially the lower signal to noise ratio that we get when using a low field scanner. We can use the deep learning methods, the AI methods to retrieve again that information, and also as well for these artifacts. But one of the trends is using the a priori information of the acquisition, the physics behind the acquisition, to be sure that we are not, for example, instead of cleaning an artifact, we are cleaning a pathological finding. So there is that careful in using that, and that's one of the trends nowadays in the reconstruction part, in the reconstruction research for MRI.
Okay, thank you so much. And you already left your email here. If anyone else have another question, I think you will be
Yes.
able to answer in a postponed way. Okay, thank you so much for
Thank
your
you so
time and
much.
for your talk. And maybe see you next year. We hope.
Yes.
Thank you.
Thank you. Thank you.
So we are now moving on with our program, and for that we will now listen to Dr. Isabel Prata, a regular participation at our course over the past years. She's a chemist by training with master's degree in biomedical engineering and also a PhD in biochemistry. She nowadays works at Ignas Pharma, but she has an extensive experience in the field of molecular imaging and in the development of metallic probes and nanosystems in biomedicine for different techniques such as MRI, SPECT, and PET. Today, she will give us a lecture on MRI contrast agents. So thank you, Dr. Isabel, for being with us again. I think you are already online.
Olá, boa tarde. Olá, Salomé.
Boa tarde, engenheiro.
Olá, Inês.
Boa tarde.
Então amanhã, Salomé, tu também vais estar, é isso?
Sim, sim.
Viva, boa tarde. Eu não estou
Boa tarde,
conseguindo
professor.
ouvir. Agora estou a
Boa
ouvir
tarde,
muito bem.
professor. Consegue ouvir?
Olá, boa tarde.
Olá, Francisco, como está? Está tudo bem?
Ainda bem
Então,
que podem entrar mais cedo.
pois, já percebi, foi a Filomena que me ligou agora. Está tudo bem. Então, quando quiserem, eu tenho que partilhar a tela, não é? Certo?
Sim. Ok.
Partilho já?
Acho que nós já estamos a transmitir, não é?
Já, podemos avançar e seguir com o programa quando quiserem.
Tá bem, então eu vou dar início. Hello, everyone. First, I have announced to Maid the previous talk was not possible to proceed because of technical issues. So it was rescheduled for the 7th of May. It was the 7th. Can you confirm that, Inês?
Yes, yes. At after the last lecture scheduled, this is at 5:30.
The 17th, yes.
17th of May. Yeah.
Yes. Okay, so it is my pleasure to introduce our next speaker, Professor Caseiro Alves. Professor Caseiro Alves is a full professor at the Faculty of Medicine of the University of Coimbra and is a radiologist specialist with extensive clinical experience. Is a distinguished expert in medical imaging, notably CT and MRI. And Professor Caseiro Alves has served for more than 10 years as the head of the Department of Radiology at the university's hospitals and has assumed several coordination roles at the Faculty of Medicine. Currently, he is the coordinator of the Medicine Master Course, and he has a significant publication record and holds positions of both clinical and academic leadership. Professor Caseiro Alves has participated in all editions of this course, and today he will be speaking on the subject of application and recent trends in MRI. I remind you that there will be an opportunity to ask questions at the conclusion of Professor Caseiro Alves' presentation, and I extend my gratitude to Professor Caseiro Alves for keeping enlightening us with his knowledge. Welcome, Professor Caseiro Alves. You now have the virtual floor. Please go ahead.
Thank you very much for your kind introduction, Professor Francisco Caramel, and good afternoon to all the attendees of this course. It's to me again a pleasure to be here. I hope my screen is correctly displayed. If not, please tell me otherwise.
Yes, we can see it.
Okay, and you can hear properly. Okay, that's great. So let's do and talk a little bit about MRI and what are the perspectives for this year. Of course, I always like to begin with some of the technical updates that mark perhaps the most important points on the major issues that we have to solve for medical imaging using MRI. This means spatial and temporal resolution. And the solutions we have today are essentially the use of phased array coils and parallel imaging. So this allows us to do some kind of high resolution imaging, especially because we can subdivide the antennas that retain the signal intensity in several subparts, as we see here. Each part is responsible for its own reconstruction of the case space. And this means that at the very end, we'll have a composite image of all the anatomy with matrices that are, in fact, very high. What do I mean by a matrix that is very high? Is running away from the current matrix of 256 to matrices that goes around 400 for each direction, which is in fact very, very high. The second advantage that expanded the role of MRI is essential an increased temporal resolution using normally hypergradients, and what the term hypergradient means that the magnetic gradient that we use to create a second magnetic field, so-called B1, is potent, normally more than 40 millitesla per meter. So this allows us to have gradients that allow the acquisition of images much faster, especially when to attain this high value, we have a very short slew rates. So these are the two advantages that I would like to sort out from the technical updates, but also to tell you that the configuration of the coils that receive the signal are going less and less rigid, like we see here, to have the aspect of a blanket, as we can see with this vendor, which is now practically commonplace with all the instruments and all the equipments of MR. And with this blanket type of coil, we have phased array coil, and the same. We have excellent image quality. Just to give you a quick glimpse of what do we obtain and what are we talking about, we can see these two images, and please compare the slew rate 42 millitesla meter per millisecond to 200 millitesla. And you can see that on this MRCP technique, we have here the common bile duct, here the Wirsung duct, and you can see it to a brighter level with sharper edges on this image on the right side. So this is what you obtain. Of course, to the non-trained eye, it may seem not a very important difference, but it is. And in fact, it allows a lot of more precision on our morphological diagnosis. Another thing that we use today is reducing the time of acquisition. And because we know that the case space is symmetric, like we do it it's the same on CT, we have essentially the possibility not to acquire the entire case space, but just, I would say, a half and a little bit more, and reconstruct the image. And then we can obtain images like this. Look at this excellent T1 weighted image with fat suppression, 20 seconds, compared with this one of only 12 seconds. The only thing we have changed is we instructed the equipment to acquire just half of the case space instead of the whole case space. So we gained time, and at the very end, we did not lose nothing on terms of spatial resolution. Another point that is important to consider is the magnitude of the static magnetic field. And we know that some of the clinical applications that are being made today are, of course, very dependent on the magnetic field strengths. Just to tell you that, for instance, today, one of the fields that needs the majority of high field strengths and benefits the most is neuroimaging, especially the brain. And for that, we go away even further from the 3T to magnetic fields such as 7 Tesla. And this already exists as a product in the market, and it is available. So basically, when we double the intensity of the static magnetic field, we double the signal, as you see here. Now, this means that you are able to obtain this extra spatial resolution. Of course, this comes at some costs, and the costs are, of course, the introduction of more artifacts on the imaging, accessibility artifacts, and this may be, of course, cumbersome to the final result. So it is a trade-off. We need to understand exactly what do we want to obtain in order to take the decision of going to 1.5 to 3 Tesla or to 7 Tesla, as I told before. Here you have an example of an excellent case of pancreatic imaging. Pancreas is very difficult to image. We have the random artifacts caused by respiration, by the bowel movements. So the pancreas is retroperitoneal, so it's very difficult to image. But look at the sharper of the edges and at the image of the Wirsung duct. This we can do. Look at the matrix. Is a matrix that is exactly the same you use on CT. So this means that it's a double of what we normally use. Look at the thickness of the slice, 2 millimeters. And here, these images were obtained with only a 4-channel torso coil, which means that we are today in a much more resolutive image than this one. On the image of the right, you can see that, in fact, the thickness is even inferior to 2 millimeters. And look at the time, the echo time, which is only 1.1 milliseconds. So we are just on the edge of using sub-second or sub-millisecond use of the TE, which means that practically this we can do and perform some images with a enormous resolution and make use of MR as we use normally CT for advanced clinical applications. Look at 2 examples. On the left side, you have an angiography with native images on the coronal plane, and we can see very well the aorta, the mesenteric, the aorta, the renal artery. So this is more than enough in order to understand and to use this kind of image to interpret what we need. And in this case, what we needed was essentially to show this artery that comes along from the aorta directly to the liver, which is a transposed right hepatic artery. So this can be made really with high resolution imaging using this type of MR. On this left side, on this right side, we can see MRCP image. And what we can see is that we are seeing and displaying the third and fourth order intrahepatic branches of the bile ducts. The cystic duct is here. This is the gallbladder. And you can see that the quality of the images is, in fact, very, very good. So what are the shortcomings? This is not only benefits. You are doubling the magnetic field, so you are doubling also your problems, because everything that moves is terrible for MR, especially at high fields. Look at what we gain, what happens at the level of the heartbeats, and all the left liver lobe is obscured by the movements. Here we have 2 lesions that are metastases in the liver. Secondly, we have replication artifacts along the phase encoding image. Here we can see along the replication artifacts of the pulsation of the femoral vessels. The same goes true for the peristaltic movements of the bowel. And of course, all of these, or the respiration, makes blurring on the image. And this is a common problem when we use 3T. So my bottom message is, it's very okay to go further to higher field strengths, but you must think that essentially you need to have very in place good strategies to reduce the motion artifacts. So to summarize and to finalize what I'm saying on the current MR, and I'm very sorry if I am showing you mostly images of the abdomen, but I think it is well when one of the most difficult applications on MRI due to the problems of movement that I told before. So the requisites when you buy a new MR machine, when you want to understand what should I use, you need to have some kind of hypergradients, and I mean more than 40 millitesla per meter, phased array multi-element coils, especially with the blanket type of coils, use of parallel imaging, and with this, what we want to gain is essentially to have excellent spatial and temporal resolution of our images. Now, here I show you on this table what is the typical image of a liver protocol. And this is some kind of sequences that we use by disorder. And of course, this makes me speak a little bit about the term that perhaps you have already heard of multi-parametric MRI. I think it's a little bit of misnomer. It's used on the prostate, but the term multi-parametric is essentially due to the fact that we use these kind of several sequences that are needed to characterize and to detect lesions. But mostly, I wanted to show you this to you because this is no longer, if you want, state-of-the-art. This is good image quality, very good protocol, but we can go further and reduce the slide thickness. I show you before images of 1.7 millimeter slide thickness. We can go even faster using special forms of acquisition of reconstruction of case space, like beginning in the very center of the image and going peripherally, because we know that the contrast part of the image is essential in the center of the case space. And all this protocol at the very end is made on a time span of 13 minutes. Today, with the use of deep learning algorithms that are applied to this type of sequences, we can, in fact, shorten this to 7 minutes. So you see that, in fact, we have a very powerful tool with enormous image quality in half of the normal time we had before. So I told you just a little bit about the basics of MRI, what we have to understand, where MRI goes, wherever the field, if we are talking about liver, if you are talking about brain, But essentially, when there is movement, this is what we have to do, is to have excellent image quality based on those parameters. The second thing that is important is that we are also developing biomarkers for liver imaging. Some are already incorporated in the routine clinical practice, other are not yet there, but I think they are for sure the future, the near future. And I wanted to discuss with you what we call diffusion weighted imaging. What is this type of concept? The liver perfusion, well, this is easy to understand since we are aiming and being able to be so fast. Why not to profit and study the perfusion, the microvasculature of the tumors of the organs? The third is molecular imaging, and I'll show you essentially with use of contrast dedicated specific contrast agent that goes to a target organ or target cell. And to finalize with a new application that did not come yet for the clinical round, but it is already explored. I can tell you that it is one of the most prolific findings and research activities for the last years in MRI, which is called radiomics or radiogenomics, whatever you can call it. And I will cover this at the very end. So let's begin with diffusion. And diffusion, here you have a phenomenon that is a physical phenomenon. And if you mixture a dye, like we see here on cold or warm water, the distribution of the liquid is completely, the dye is completely different. And this is related to the capacity, to the capability of, to the thermal agitation and the capability of the water molecules to diffuse along the interstitial space. This is what happens in the tissue. Let's imagine this is cells in the tissue. This is the interstitial space. This is a vessel carrying the plasma. And what we have is protons that are here in the interstitial fluid. Of course, we have also protons in the cytoplasm of the cells. But let's for now just fix on the interstitial space. This means that if we have, imagine the double of the cells, the protons within this interstitial space would not move, will not be able to move, to show movement. And for this reason, we say that they are have a modified, they have restricted diffusion. Instead, if there is lots of interstitial space, of course, the cells can, the water molecules in the interstitial space can move freely along the cells. Let me show you what is the Brownian movement of the cells. Here you have it, the random movement of the protons within a certain magnetic field. And so how can we explore this, this effect, this physical phenomenon? Here we have the typical sequence of MR with a first pulse of 90 degrees and then a second refocusing pulse of 180 degrees. Between them, we use so-called sensitizing gradients, which are no more than a second gradient that is used, that is connected and is rapidly disconnected. Then we wait for the refocusing pulse and you use finally another pulse of this. And the idea is to try to put all the protons in the interstitial space pointing out in the same direction, meaning they will have high signal intensity, as we see here, if they have an environment with lots of cells inside. So they point out towards the same direction. This means high signal in our coils. On the second example, we see exactly the same figure and schematic drawing of the sequence. And now what you see is the free diffusion. So at the very end, when we apply the second gradient sensitizing gradient, we can see that in fact they point out whatever the direction, and so they do nullify themselves, and the signal intensity will be zero, tend to be zero. So how do we see this on our images? Now, imagine that our signal intensity is here, and here means the longitudinal direction of the protons, and that then we apply the sensitizing gradients to these protons in the interstitial space, and we see that they are exponentially relaxing according to the b-value, as we see. So the longer our sensitizing gradient, called b-value, the more our protons will show signal intensity. This is, of course, correlated with a formulation that says that signal intensity equals the 0.0, which basically it's a T2 weighted sequence, multiplied by the exponential of the value of the b-value of our protons. So this finally gives us images like this. We have here several metastases. Please note that the blood within the vascular structures is black, completely black, which is the perfect integrative background to understand what is happening with these nodules. And this is a longer b-value, meaning more restriction effect. Of course, we lose signal intensity from all the interstitial space that does not have restriction, but we increase those ones that have restriction, and we see the metastasis to better advantage. Clinical practice. Let's show you an example of what happens normally with a sequence T2 weighted. This is a rapid sequence. This is a conventional sequence T2. These are the best sequences used in the past, and we don't see any metastasis. This is an oncologic patient. When we perform diffusion weighted imaging, look at the metastasis, and we can see it now here, perfectly sub-centimeter lesion, which is here, near this vessel. Of course, the problem is that all these vessels are refocused by the way we obtain and try to minimize the artifacts from the vascular structures. And this is the reason why this sequence is in fact so good, because it explores a new magnetic property, which is the restriction on diffusion weighted image. We can complicate it a little bit further. This is already a little bit complicated, but we can in fact complicate a little bit further if we think that in fact in the plasma of our capillaries, we have lots of protons that are there. And also they suffer exactly the same distribution, the random distribution, and we can profit the occasion to magnetize them. And this is the reason why you have a B exponential curve of decayment, as we see here, when we in fact use the T2 weighted image. And we have a first exponential decay here, which is called the fast component of restriction. And later on, when we use higher sensitizing gradients, the intersection of the curve is in fact another one completely different from the first one. And this is called in fact the IVIM phenomenon, intravascular incoherent motion. This is much more complex to analyze, but it's just for the sake of completeness to say to you that here we have the B exponentiality of the curve, now amplifying just the first part of the curve to see it better. And we have this value, you have the D star value, which corresponds to the restriction within the vessels and not within the tissues. That's the difference. So we can measure it also. So basically, and this is the true diffusion or D. And so basically what we are just saying here is that we have an access to an indirect access to the perfusion of the organs using this expression and using this component of the B exponential curve. So we can derive what is the vascular fraction of diffusion. Clinical applications, again, we see that imagine essentially on the response after therapy. Look here for this large tumor. The parametric map shows a certain amount of restriction, lots of restriction. which is completely different. The restriction goes down, and we can see the modification of the histogram from one to the other. And we see that the tumor is now shorter, and after therapy that things are completely changing from pre to post therapy. So this is one way of analyzing the response to therapy. Just going a little bit further to this new biomarker, because the current biomarkers will only allow you to measure the dimension of the lesion. And this is not true with the current therapies that are being used, that are mostly directed to the vascular component of the lesions, and not essentially giving a cytotoxic effect and a modification of the size. Well, there are even further complicating factors that we can use, in fact, with diffusion. So we see that we are exploring still this possibility of quantification of the Brownian movement of the protons within the interstitial space, within the vascular space. And now, furthermore, if we use several points during our B exponential line, we know already that this is the first component, this is the second component. But if you go away from a B value, a sensitizing value like 2000 or 3000, normally what we use is 1000 millitesla per meter per millimeter. We can see that in fact we have here another effect that is independent of the interstitial space. It's only dependent of the diffusion and the restriction to diffusion of the protons that are now within the intracellular protons. So this is even another way that we can use, and the difference to the traditional diffusion to kurtosis diffusion may be shown here, as we can see on this case. And if we analyze the values, the true diffusion is 1.71. Pre-treatment, pre-medical treatment of hepatocellular carcinoma goes to 1.44 after treatment. So this means that we cannot, in fact, derive many conclusions. Is there response to the therapy? Is this a case where the patient does not respond? That's a problem. And if you use this new value, kurtosis, we see that was previously 1.25, and now is just 1/3 of this value. So this means that, in fact, the tumor is responding to the anti-angiogenic therapy. So I think I made a voyage to this difficult topic, but this is a biomarker that exists already in the clinical arena, the clinical scenario. There is excellent correlation between what we get on diffusion and we see on this linear regression that there is excellent correlation with necrosis percentage on pathological examination. So basically what we can see is a lesion here that we are studying after certain type of local regional therapy, like infusion of drugs or whatever, and it modifies the diffusion value inside. So first of all, we are again going quantitative, having the possibility to measure. Look at the size of the lesion pre and post treatment. It is practically the same. It's very difficult to know. And using this approach, things may be, in fact, easier to understand the changes. We can even calculate what is the increase, the volume increase, and the increase in the ADC mean, and give finally an answer to the clinician. So the second topic I want to discuss with you regarding functional imaging of the liver is perfusion. Perfusion is a little bit even more difficult. And what happens is that we have lots of possibilities using this biomarker. Let's go for an example of a liver full of metastases, as you see here. This is not MR, this is CT, but is nevertheless the same. What we are entitled to use on the clinical context is so-called RECIST criteria, which allows us to measure one diameter or two diameters of the lesion before and after treatment. And we categorize the lesion saying that is a decrease in size of 30%. This means partial response, or disappearing, total response, or increasing, which means relapse or means recurrent disease. But in fact, what I have tried to say to you and to show you before with diffusion applies again here. Look at this metastasis that has a rim enhancement on the liver, and look what happens after treatment. The lesion is basically the same size, but the behavior after contrast enhancement is completely different, because what we are nullifying, what we are eliminating are the vascular component of the metastasis. So this is the trend. This is what we want to show, what we want to study. What is the perfusion of the lesion after treatment? This is the goal. To do this, it's on the liver is a little bit more difficult than, for instance, perfusion parameters of the brain, because the liver has a dual blood supply with a hepatic artery and a portal vein. So things are a little bit more difficult. I'm not going to enter on details because I think you may not be radiologists interested on that. I want just to explain to you the importance of this technique. We can, in fact, use mathematical algorithms to derive time density curves or time intensity in magnetic resonance after administration of contrast. Here we have the injection. This is time. This is the signal intensity. And here you see the time to peak, and we can calculate this time to peak, the plateau of the peak, and the washout, the curve of washout. So these are semi-quantitative parameters that can be, in fact, used to lesion characterization, early detection, response to treatment, or prediction of response. Of course, these are more advanced mathematical models, and we must think, for instance, that the contrast is here within the sinusoids, which are the vessels that go inside. Then there is an incomplete membrane made by hepatocytes, which have windows called fenestra. And then the contrast goes to the disc space, which is here, and penetrates finally a little portion in the hepatocytes. So we can measure the interstitial space again. And so this is the goal, is to know our input function, which is the contrast within the artery. And then we can use a dual compartment, because here in the liver we have the hepatic artery, we have the portal vein, and we can, at the level of the outflow tract, which are the hepatic veins, calculate the amount of contrast that goes out of the liver after staying in the interstitial space of the liver. And with this, we can, in fact, create images like this one. This is a huge tumor with a region of interest delineating the tumor. This is a parametric color map. We can see that, in fact, there are red areas that correspond to the more perfused areas of the liver. And now we can calculate not only the semi-quantitative factors, but also quantitative ones, like the blood flow here, the blood volume here, the mean transit time here, or the permeability surface. So these are, in fact, biomarkers of the way the contrast distributes and diffuses itself within the lesion. And this is very important. And of course, we can compare it before and after treatment. Look at the case. This is a metastasis in the liver. Again, the parametric map shows that the red means more vascularization. These are two images after contrast administration before using the treatment of this neuroendocrine tumor of the liver. Look after treatment, and the size of the lesion practically is the same. What has changed is only the vascularization inside it. So this is the biomarker we want to explore, meaning that we have now a reduced blood flow and a reduced permeability. So I tried to explain to you the potential applications in oncology of this biomarker. First, the vascular infiltration. Of course, it may serve to us as a biomarker of tumors that are more aggressive, the tumors that are less aggressive. Secondly, response evaluation, as I has been explaining to you, as a prognostic biomarker, especially the aggressiveness of the lesion, its vascularity, and of course I can use it also to characterize lesions in order to understand that some tumors, like for instance differentiation that is very important between two malignant tumors of the liver, primary tumors, may be made on the basis of its perfusion abilities. Now, what are the problems related with perfusion? Why is not perfusion on the clinical arena like we have it on diffusion-weighted imaging? And essentially, this is due because there is a huge variability on the signal intensity. This is due to lots of factors, but essentially related to artifacts on the MR imaging itself, coil positioning, technique, and so on and so forth. And even to complicate even further, two commercial packages from different vendors may not talk with each other, and they perhaps provide different results. And this has been a huge problem. There has been even a study that tried to see what happens to the same tumor in the same individual, studying different time spans, and in fact they show that in fact the results were variable. So this is basically what is going wrong on this technique, but this is very important. And you may ask me, why am I showing this image here? And remember, we are talking about new trends of MR, and this is one of them, is so-called compressed sensing grasphi. What is the difference between this and the other sequence I showed before? Here you have the patient in normal breathing, so there is no apnea periods, which may vary from patient to patient, or even with the same patient. And secondly, we just inject contrast, and the algorithm that we use is able to provide us reconstructed images, 20 images, 40 images, of with an excellent resolution of different phases of the passage of the contrast. So this principle is very interesting as a baseline technique in order to calculate the perfusion of the organs and the perfusion of lesions. And just to show you another example in my clinical practice, here you have a huge tumor. Please look at the aorta without contrast, now with contrast, and look at the enhancement of this lesion, the relationship with the portal vein. So you can see exactly what is going on a time-resolved manner, which is in fact very important. So perfusion, to summarize, very interesting, very important. We may be able to do it and perform it better using CT because it's less prone to this problem of artifacts, but nevertheless, with the new techniques, I think it's very important to think about perfusion as a biomarker in the future for evaluating tumor response. Point number 3, functional imaging of the liver using contrast agent. Now we are shifting to a molecular approach. What we are using now is a contrast agent. Here we have several names of contrast agent. They are all derived from the same molecule, gadolinium, which is basically as electrons that are free, at least unpaired electrons that are responsible for its magnetic moment. So it's a little bit different from the contrast on CT, because here what gadolinium does is to modify the magnetic moment of the water molecules that are around what we call the inner sphere movement and the outer sphere, the second sphere and the outer sphere. So they are able to modify the relaxation times. And this is the reason why the vascularization of organs show hyper intensity, hyper signal when we inject contrast exactly due to this. So this is, I would say, the basic concept over the extracellular vascular, pure vascular agents that only diffuse to the interstitial space. But now we have another one, another contrast. And this contrast, when it goes on the sinusoids, as I showed you before, goes to the space of this, as I told you, they diffuse to the interstitium of the liver. But now, because they have a different chemical composition with a benzenic ring, creating lipophilicity, and they are prone to be recognized by membrane receptors. These membrane receptors are proteins that, in fact, are able to capture the molecules of contrast agent with gadolinium, internalize the gadolinium inside the hepatocytes, and then by the action of another transporter within the hepatocyte itself, transport the gadolinium to the bile ducts. So for the first time, we have an enormous opportunity of understanding what is happening on this molecular imaging or molecular transportation for this functional imaging of a transport system. And what we have with this contrast in the real life is this. Here is the benzenic ring I was telling you before. And here we have the first passage of the product diffusing to the interstitium. This is exactly like a regular gadolinium chelate. Then it goes out of the lesion on the protophase, and especially 20 minutes after injection. Please note that the signal intensity of the liver 20 minutes after injection, when we have no longer contrast within the aorta, is completely different from the arterial phase. So this means that, in fact, there is retention of the contrast within the normal hepatocytes, but not within the tumor, because the tumor is not composed by hepatocytes. So this is the reason. And what we can see, in fact, is that we are able to understand, for instance, look at this case. We have a tumor here, again, is hypervascular in the first phase, then it fades away, but then on 20 minutes after contrast, is completely different from the other one. And now it takes a lot of contrast. So this receptor still exists within this tumor, showing to us that we are living with a benign tumor that does not need to be operated. And so this is one of the major, I would say, interests of this contrast when we have problematic problems in MR imaging studies. Look at this case. There is a lesion here on a young female patient. We do not understand it. It's heterogeneous on T2 weighted image, not too much restriction on diffusion. When we inject contrast, this contrast agent, we show that it is again heterogeneous, not enhancing heterogeneity on the porovenous phase. And look now, on 20 minutes after injection, the liver is homogeneously bright. So this means that all this area is not a real tumor, but it is a pseudo tumor of the liver, and the patient does not need to do biopsy, does not need to do anything else. It is a benign liver lesion. Look at this one, again, very similar to the previous one I showed you. Same signal intensity on T2, we practically don't see the lesion, the same on T1. When we perform a special sequence, here is the lesion, we see it now very well. It enhances on the arterial phase, but different from the other one, as you can see, 20 minutes after injection, it now turns off to be hypointense. So the mechanism of retention, the mechanism, the transporters do not exist inside the lesion. And this is a lesion that is exactly maybe rotulated as an hepatic adenoma, for instance, which normally means surgery. So you see the importance of this is, in fact, to show that 40% of our standard MRI cases we were not able to say anything about that. If we join this contrast agent, our sensitivity increases and our positive predictive value also increases. Another issue that these contrast agents can expand, I would say, the clinical applications on liver imaging is, for instance, for a very important clinical problem, which is major liver resection. When we are planning to operate a patient, the problem is, can the patient stand for the operation? Is the patient going to have enough functional and good liver on board in order not to develop postoperative hepatic insufficiency and possibly death? So this is a very important question. And what we can see here is, in fact, that we can use this contrast to show what areas are, in fact, normally enhancing, meaning that this is preserved parenchyma with functional good capabilities. So a kind of indirect demonstration of the functionality of the liver, compared with the right liver lobe, which was, in this case, was embolized. The flow to the portal vein is one of the techniques used to try to increase the amount of functional liver. And we see that it will be at the very end, we can calculate the volume of this part of the liver and say, no, don't worry, the patient can be safely operated, will not develop hepatic insufficiency. Look at this case, the excellent enhancement of the liver after this contrast. They wanted to operate this lesion. They want to do a right hepatectomy on this patient, or at least posterior segments of the liver, doesn't matter. But the eventful recovery was observed and the discharge after 6 days. At this patient, for instance, the enhancement of the liver is very, very poor, although there is contrast already in the bile ducts. But the enhancement of the liver is nothing compared to the one that is normal, and we know very well what is a normal visual impression of a normal liver enhancing. And this patient had, in fact, postoperative complications, discharge only 22 days of hospital stay with decompensated ascites. And I finalize here telling you that, in fact, this is important. EOBD-TPA is the name of this contrast, the generic brand, and it is very important for those that work especially on tertiary care hospitals dedicated to hepatobiliary imaging. And finally, the new kid on block, and please again think that this is maybe applied in many circumstances, not only liver imaging. I just brought to you liver because it's my field of interest, not and it is my subspecialty expertise. But what is radiomics? This designation of radiomics that comes, of course, from the terms that we know, genomics or proteomics, metabolomics, and also there is now radiomics. What is radiomics? This comes from a fact that images are not just only what we see. There is information inside the images itself. They are not available for discrimination by the human eye, but they can be, in fact, observed, interpreted by the computer. And of course, if this data within the voxel itself, essentially expressing if there is homogeneity, heterogeneity, patterns, etc., can in fact derive a series of agnostic markers like kurtosis, Heraclid textures, loss textures. So these are statistical measures of what is happening within the liver. And these, I would say, contrarily, the opposed to what we are used to describe on the semantic world, where we radiologists describe the size, the shape, the vascularity, speculation, necrosis or not necrosis, but visible to the human eye, contrary to these agnostic dimensions of the lesions. So to do this, it's very simple. We can, in fact, segment the observation, which in this case is this mass here. So the tumor or whatever is segmented from the whole volume, then is renderized in 3D, and afterwards it is applicated the data segmentation, extraction, and the reading by the big data of the computer in order to give you this type of a flow chart, which is difficult to interpret from the human eye. We need to know exactly what are the patterns of this tumor. So we can compare, for instance, imagine one feature, it is what is seen here, which is some tumors have a microvascular invasion, some tumors has not. So the question for radiomics is, are we able to distinguish this without operating the patients? Because until now, we are not able to do it. So this is the clinical problem. And what the radiomics show us is that, in fact, the tumors that have a microvascular invasion are different from those that do not have it. So it is an enormous amount of possibilities of research on this area in order to derive again different biomarkers from the simple interpretation, visual interpretation that the radiologist is able to perform. Of course, this needs many things. It means homogeneous data. It means curation of the data in order to be extractable. It means excellent image quality. We cannot compare lemons with oranges for sure. And big data. And this is possible with the current biobanks. For instance, if you want to study this feature, the microvascular invasion in a specific tumor, we cannot do it in 50 patients. That's nothing. We need to understand it in at least 1,000 patients. And this is not available to any hospital. So this is only available on imaging biobanks. And this is the importance of the construction of this and the construction of AI algorithms in order to derive radiomics. Here you have just a review. It's a relatively new review where we see the future perspectives. I just took this image from this paper, and look at the column on the right. What we see, we can use it on CT, MR, US, whatever, nuclear medicine. So it's always the same. Where there is a voxel, you can do it. And for instance, look at the applications, prediction of HCC and hepatic hemangioma, prediction of microvascular invasion, as I was explaining, a prognostic model for metastases or early recurrence. So essentially, they are biomarkers of tumor response or prognostic biomarkers. So this is the goal that we are studying so hard. Why do not have it for yet? It's because, in fact, again, the problems of heterogeneity of the sample size, and we are now seeing it more and more. Many companies, startups that are using these techniques in order to analyze, for instance, prostatic cancer, gynecologic cancers, liver cancer, lung cancer, glioblastomas in the brain, whatever. So I would say to end up that we need to think on multidisciplinary teams, that there are enormous amount of things happening at the cellular, subcellular level. And these are the hallmarks of liver cancer. In speaking essentially of clinical applications in the field of oncology, we could talk about, of course, with different problems of different areas. And to the moment, I'm just focusing on oncologic imaging. So we can derive cellular density. We see that diffusion is very good for this. Of course, we can derive on cell proliferation, and here we go again to diffusion, but we go again to PET, because PET is a good biomarker of metabolic activity. Angiogenesis, again, think about the possibility of dynamic contrast enhancement and perfusion studies. And of course, very related to this, the possibility of studying hypoxia which is a very important biomarker when we want to understand if a tumor is going to respond or not, for instance, for radiotherapy, because tumors that are hypoxic respond worse to radiotherapy than patients that have hypervascular tumors. This is something that is known. And so on and so forth. So there is a lot of opportunities to study many biological biomarkers. And we are, I think, just in the verge of beginning this. But of course, we need to understand that we are not alone. And many things are done on the clinical scenario that are, I would say, adjunctive to the imaging biomarkers. And they are really important. One of them is, for instance, perhaps you have heard this expression, what is called a liquid biopsy. And the liquid biopsy is something that we are going to extract from a sample of blood, a peripheral blood, and to be able to calculate and to derive and to see if there is any metabolic elements of the tumor produced by the tumor, or if we can see, for instance, DNA fragments within the bloodstream. And with this, we can, in fact, help to prognosize better our patients and treat them better. For instance, taking it longer for the radiotherapy courses or the chemotherapy courses, and so on, and to understand if you use a first line, if you use a second line, if you go to immunotherapy, or if you go to whatever. So this is, I think, one of the most interesting fields of research. NMR is not a component, is one of the key components for all of these things. I would like just to end up saying that and finishing a little bit like I began, and saying that deep learning and artificial imaging is very important today. I've already told you that on deep learning for the reconstruction in images, reducing the noise, the intrinsic noise of the images without doing nothing, and allowing to make images faster and with higher resolution. We had a work that was published some time ago with this, and if we compare the lesion conspicuity between the classic images and using of deep learning, which is obtained in 45% or 40% of the time we used previously to do it. And look at this example of a tumor on the peripheral prostate, is this hypointense nodule, and look how we see it on the images using deep learning with a faster imaging. So this is one of the importances, and this can be applied wherever. Compare, for instance, deep learning reconstruction in the brain. Look at the granularity if you're in this image. Look at the same image on 1.5 using the deep learning algorithm. It vanishes completely the noise, and of course makes the image very likely a 3D image. And just to tell you that I am talking here about going higher fields and 7 Tesla fields, but also deep learning allows us to go down. And these are clinical examples, not of 7 Tesla, but 0.5 Tesla. It's incredible. Images are of super high quality. We can even do and perform diffusion-weighted imaging. Look at this diffusion-weighted imaging with a B-value of 800. This is amazing because diffusion is one of the properties, the magnetic properties of the magnet mostly are important. And the higher the field strength, the higher the restriction we have. So it's fantastic. It's a new world. And with this, I would like to finalize, I think, in time, saying that we have an enormous potential for the use of these surrogate biomarkers on cancer imaging, data mining, and I think that biobanks, and we are strongly concurring with this within our university because we think this is the pillar of precision medicine, no doubt. And I think we are still not there. And when we are already there is using artificial intelligence and deep learning reconstruction on behalf of the quality of our images. So I think this is what I have to tell you on behalf of MR. We can discuss a lot of other applications, but just to give you a glimpse of those that I think that in my personal experience are very important. Thank you very much for your time, the time you have wasted on this talk, and it is a pleasure. Now I will interrupt my sharing and I regain the moderator, Professor Francisco Caramel. Thank you very much. Now I finished. Francisco, I don't know if you are there.
Yes, thank you. Thank you so much for your excellent presentation. There is a question that is in the chat, but
Okay.
I can read it for you. Say, magnetic resonance imaging technique captures signals from the nuclei of hydrogen atoms. In diffusion weight images, how is the signal from intracellular and extracellular water molecules distinguished? Does
Well,
it all depend?
it's a very good question. Of course, there is no distinctive features between intracellular or extracellular water because the protons are exactly the same with the same precession frequency. So it does not change. What is different is what are we exploring, and instead of using a B value, imagine of 1,000, we are going to 3,000. And what we know is that all the restriction to all the diffusion that occurs within the interstitial space has already vanished. We are not there recovering the signal from them. We are just recovering the signal from the protons that are within the cells. And this is what we know that from the experience that were made. And this is the only way we have is to extrapolate that in fact we are within the cells that are within the cytoplasm of the cells, and we are within the hydrogen of the cellular content. But there is no, I would say, hallmark different from the intracellular or extracellular. It's just a question like, it's like I'm doing a T1 or T2.
Yes.
T1 or T2, it's not different from 1.5 to 3 Tesla. I am exploring 2 dimensions, and it is the operator that chooses the parameters in order to go to explore the 3 dimensions of diffusion. First, the vascular one inside the vessel. Second, in the interstitial space. Third, with kurtosis, the extracellular space, the intracellular space.
Thank you. I think there is no other questions, but I don't resist to make some questions, because what we are seeing, not only in this subject, but all over many other subjects, that the evolution is accelerating, and it's so fast that it's difficult to keep the pace. In your opinion, can you preview what can we see in about 2 years, 3 years?
I think that we are going to see an explosion of AI. AI, the major question is how are we able at the hospital level, at the department level, able to take profit of these new technologies? Because for instance, take a department of radiology. Now we have technicians, we have radiologists, basically. Now we have to have a third component, which are the data scientists. And basically what we have to understand is, what are we going to take in our departments? Are we going just to be recipients of the AI developed by universities and so on, sold to the industry, and they came to us by the industry? This is one way, and it is what is happening today, because, for instance, there is already an AI that is used in conjunction with CT for reduction of the dose, and which can reduce the dose in about 40%, and extracting the quantic noise from the images. And this does not come to us as something we have to develop. It comes just as a finished product, you see?
Yes, something that comes from the shelf.
Yeah, the universities need to fabricate it tomorrow. So we need to be the factory of tomorrow. So we need to have data scientists on board. We need to develop algorithms. We need to develop and be able to create these biomarkers and explore them, perhaps not alone, but on huge biobanks, exploring this and that. I'm going to give you another example. In the Faculty of Medicine, where we belong, here in Coimbra, we are now a federated institution of EUCAIM, which is the European database for cancer imaging. And what is the goal? Imagine that you want to study glioblastomas, and one of our colleagues has a lot of collection of glioblastomas, but the lot of collections is what? 30 glioblastomas? Now imagine
Yes,
you have a biobank and you have 1,000 biobank, 1,000 glioblastomas. Now you can explore them in every way. So you can foster and accelerate unprecedentedly, for instance, clinical research, clinical studies, you see, and make it completely different approach. And even the testing of drugs may be completely different. So can be used in vitro, whatever. So I foresee, and it's not a great, it's an enormous modification of all our activities. I didn't speak about many other things that, like, for instance, the nanoprobes, like magnetic agents, so many things like the hyperpolarized MR that explores metabolic function of the MR. So it's a enormous bunch of things. But to be honest, from the playground we have for today, I think it's image quality still, and it is these biomarkers that I have explained. That's what we are seeing appearing now, especially deep learning to decrease, because it's very good, deep learning, because the workflow and the availability of the machines increases because we are increasing the throughput of patients. But now we are going to have more and more the need to have biomarkers for diseases, for specific diseases. And I give you another example, for instance, prostate cancers. Until now, oh, prostate cancer is a surgical lesion. It is not. We know that the certain cancers of the prostate vary a lot. And we may, until now, have the need to do a biopsy and grade the tumor and go to the Gleason score and this and that. But this even does not show you the whole picture, because you are maybe puncturing the wrong zone of the prostatic nodule. So you don't know. So if you have a biomarker that shows you that these characteristics correspond to this and that and that and that, and you show that by the evidence created by thousands of examinations on biobanks, including on a pathology imaging, so you have the answer for a clinical problem. So I think the goal now is essentially doctors, technicians, whatever. We should set the scene, and we should ask the questions and ask essentially, which are my unmet clinical needs? And with that, with my unmet clinical needs, we go to the data scientists, we go to you, we go to Miguel Castelo Branco, we go to whatever, and we ask you all, how can we approach
achieve that?
And this is how I see it, multidisciplinarity.
Yes, of course. Meanwhile, we have a new question. Can you please elaborate a little about the synthetic CT generated from MRI, advantages and disadvantages?
I would love to. It's a very good question. I see that we have a very profound knowledge of those that are hearing us. And this is completely true. It is possible to generate synthetic images of MR, or better said, of CT using MR. I'm not exactly knowledgeable about the mechanisms that we can do it. I know that it is possible to do it. I know you can generate, even calculate densities. So it's a possibility. But to be honest, it's like, for instance, speaking about radiology and black energy. What is black energy? I don't know. So there are so many things. So for instance, it's like CT and photon counting. We just have photon counting for the last 2 years. What is photon counting? So we need to understand exactly the developments. And as Professor Caramel was saying, this is so fast, that in fact, we cannot tackle everything. So if we don't have I would say, a special research lab on this or that, perhaps if you ask this question to Professor Pokizer, for instance, or Professor for another, for someone who works in a laboratory of CT, he may explain to you for sure with a high advantage. Sorry for not being more precise, but it's because I cannot. So I don't know also.
Okay, thank you again. I think we have no other questions, and I would like to thank the attendees, and just a reminder that is in the chat webinar about the lecture from Dr. Isabel Prata that has been rescheduled for May the 70th. The 70th, yes, in the 5:30 p.m. and it is about MRI contrast sections. Okay, thank you all. And,
I will be tomorrow with you, I think, again, if I'm not wrong. It's not you.
Sorry?
I will be with you tomorrow, or not to you, but with Austin. I'm in the program tomorrow.
I think so. I think I'm giving the lecture tomorrow.
Okay. So we'll be together tomorrow. That will be great.
Yes, again, yes.
Thank you very much for all of you, and thank you very much, Professor Caramel, for your kind words. Bye-bye.
Thank you. See you.